and prevent any other things from filling the keyhole. This drug is not going to prevent the release of histamine. Once histamine is released, some of the histamine will be in the keyhole and some of the Benadryl will be in the keyhole. So you will still have the effects of the allergy. It won't be an immediate release, but it will lessen the effects because some of the keyholes are filled by Benadryl. And that's important that you know that it competes, and so it's not a first-line drug. So if somebody's having an anaphylactic reaction, an acute allergic reaction, this would not be your first-line drug. You would have to go to your epinephrine. Now, it also affects the action of acetylcholine. Bringing you back to anatomy and physiology, all of those normal body things that happen at key and receptors happen either through our central nervous system, peripheral nervous system, or through our adrenergic system, epinephrine, norepinephrine. The ones that happen where our central nervous system, peripheral nervous system nerves at the synapse meet the cell are mediated by acetylcholine. That's the mediator. Now, Benadryl affects the action of acetylcholine. It affects that. So if it fills the same receptor and competes with acetylcholine, then instead of having the vagus hit the SA node and slow the heart rate down, some of that won't happen. Some of it will, but not all. And so our heart rate will be a little faster after taking Benadryl. We'll have some CNS depression. In other words, we won't be as alert in our brain because some of the receptors will be filled by Benadryl. So we'll be sedated. We'll have drowsiness and lethargy. And we'll also have xerostomia. We call these effects of Benadryl, and if you looked up in your book for any other drug, any drug that acts competitively with acetylcholine, we call anticholinergics. They work against acetylcholine. And so when you look up under your things, what about Benadryl, and you're reading your little package inserts for what drugs are available in your office, because you may very well be the person that's assigned to draw up these drugs and hand them to the doctor if he wanted them. Well, you'll see that that word is there. It's an anticholinergic. It competes again with acetylcholine. Any drugs that cause CNS depression will increase the sedative effect of Benadryl. And any drug that causes dry mouth will increase the xerostomia of Benadryl. So if a patient's already on a medication that causes xerostomia, their chief complaint after we place them on this medication may mean, I can't swallow. I don't have enough saliva to even swallow. So these may be people that we want to say, okay, you can use the Biotique products, the oral salivary lubes to help you with this because they're going to need this medication. The next medication that is in the kit is called Solu-Cortef. Now, Solu-Cortef is an adjunctive therapy again. So I personally, in my office, would not have an algorithm that a dental hygienist needs to do any of that injecting with Solu-Cortef, because it's something that can be handled very well by the postoperative physician that's treating this emergency. But it is there, and it may be that your particular doctor wants you to draw it up and be an assistant to them when they are in the office, and so you should be familiar with it. And we use it as a secondary drug to limit swelling and inflammation from allergic reactions. It has a rapid onset and a short duration of action. It promotes membrane stabilization and inhibits the biochemical mediators of inflammation. It comes in a little bottle. It's called a mixo vial. There's powder on the bottom, liquid in the top, sterile saline. And it comes in 100 milligram little mixo vial for 2 mLs. But it should be titrated. It can be repeated. This is not something we would do in an emergency, repeat Solu-Cortef. We would give maybe one loading dose and then transform out to the hospital, okay? But in most situations where you're practicing under a general supervision, you would not be injecting this. Now, how it works is you twist the little rubber top on the Solu-Cortef so that the liquid flows into the powder, and you mix it all up and roll it. It has to be totally clear. Remember, if there's any particulate matter in any drug, we would never want to inject it, okay? Drugs have got to be clear, okay? So you're totally clear, and then we would clean off the little rubber stopper with an alcohol swab and pull up the material, and in this particular case, hand it to the dentist that would be injecting the patient. And then we're going to inject it into the muscular part of the body, such as the thigh or the upper arm, and when possible. And with this particular drug, it's not impossible. It's not a first-line drug. Clean the site of the injection before you inject. You don't want to put any dirt or germs into their skin. And so the drug bottle looks like this. You twist this. That forces the fluid down into here. You roll it in till this portion down in here that's all powdery becomes totally clear. Then you draw it up and inject it. This one's easy. This is one you can use as a first-line drug. And that's ammonia, spirit of ammonia. And it's used in cases of vasopressor syncope, which we'll review. And you take a capsule, you crush it, you wave it under their nose. And how it works is this noxious odor stimulates the respiratory center of the medulla. In other words, you wave it here, it smells so bad, the patient takes a reflux inspiration to clear their air passages. So the last thing we want to do is keep that under their nose, because if they take this reflux inspiration, we're going to burn the nares and burn these respiratory passages with this strong ammonia, right? It's just a quick swipe, move it aside, let the patient recover. Now, cardiovascularly, it will increase the blood pressure and the heart rate, and it can cause a bronchospasm. So everything we do may have an equally and potentially dangerous sequela. Sometimes it's better to do nothing and just support the airway, do CPR, than to get into our drug kits where we tend to create another problem, especially in somebody that's asthmatic. The next drug that's in there is our albuterol inhaler. And albuterol is used during the acute asthmatic attack, during anaphylaxis, to control bronchospasm. Now, the best inhaler that you can use in an emergency is the patient's inhaler, okay, the patient's own metered inhaler. So if you have a class 2, class 3 asthmatic patient, the first question should always be, do you have your inhaler with you? The problem is, when they start to have this asthmatic attack, they start going through their handbag, they left it in the car, they only brought their cell phone, and, you know, you've got a nightmare going on, okay? So if you had that ahead of time, and you did that as part of our patient interview, then we're going to prevent a big problem, okay? We're going to prevent the problem. Now, albuterol is a beta-2 adrenergic drug, selective, meaning no cardiac effect with albuterol, or very limited cardiac effect, okay? Rapid onset, and the duration of action is up to 6. Now, it also reduces the mucus production and inhibits histamine release. But the major reason we use albuterol is to get a bronchodilation so that more air is delivered to the airway. They look like this, you know, patients, you uncap them. In a bronchospasm, you'd give 2 puffs in this metered dose, about 2 inches from the mouth. In an acute asthmatic attack, they may need 4 to 8 puffs, okay? You need 4 to 8. their own metered dose is the best. So when an asthmatic attack is starting, they'll get their medication. The metered dose, whether they're to take 3 puffs, whether they're to take 4 puffs, they know that, okay, and let them administer it themselves. However, if after the patient's administering this, and you're saying how many doses do you normally take, and you should know that from your medical history, right? If somebody's asthmatic and they have a bronchodilator, you should know how much is regular for them. If they've delivered 4 or 5, because they're still not breathing, this is an ominous sign. I'd get the EMS on board, okay, because whatever they normally do, it's not working now, okay? And remember that the dental office is just full of triggers for asthma, you know, glutaraldehydes or scents that people are sensitive to. You know, I see some offices put candles and things in. Probably not prudent, because we do see a lot of asthmatics in our society. Okay. Now, nitroglycerin is in our case too, and this is another one that the patient usually has his own or her own metered spray or dose, right? They carry it with them. They know how much they normally take. They know how much normally aborts their anginal attacks. It works by being a vasodilator, and we place it under the tongue for up to 3 doses, or a metered spray. Now, the metered spray is preferred by some practitioners because it stays fresh, where once you open this, it starts to deteriorate. So you almost have to throw the whole bottle away after you open this. In my particular hands, if I had to give the lingual spray anyhow, it would be dirty. I'd throw it away anyhow. Now, one thing you have to be cautious of when someone's using nitroglycerin is the blood pressure is going to drop. So you don't want to be administering this to a standing patient. Make sure they're already seated in a semi-reclined position. And nitroglycerin is a coronary and a peripheral vasodilator, and as such, it'll increase the oxygenation to the heart muscle. But the second added benefit effect to nitroglycerin is this significant venous pooling that occurs because it's a venous dilator. Less fluid, less blood is being pumped back to the heart. Some of it's staying out into the peripheral area, and so the heart doesn't have to work as hard. So you decrease the work of the heart, called the cardiac preload. Cardiac preload, if you're reading about this, you decrease the preload, the work of the heart that it has to do with each beat. But second of all, you increase the oxygenation to the heart. And because of that, the heart quits hurting. It's got enough oxygen, the cramp goes away. Now, these people are used to their anginal attacks. They know how long they normally last. They know what their medication that takes them away. But I would say that you have to know what they normally do, how often they last took their nitroglycerin, how often do they take their nitroglycerin, in order to make an assessment on whether or not this patient is getting better, worse, or staying the same. And that's where we go back to the beginning of the morning, interviewing that patient, finding out how stable they are. If they have stable angina, that maybe once a week they take 1 tablet under their neck or the tongue, and they're fine, that's stable. But if, in fact, they're saying, well, you know, actually, I've had to up my dose a little bit, and, you know, I've got an appointment with the cardiologist because I couldn't get in for 6 weeks. This may not be a patient that's appropriate to be seen when the dentist is not physically present in the office. And the only way you're going to know which ones are or are not is by that interview and making some statement as to their stability. Now, you're going to have the rapid heart rate. Because of the vasodilatation, you're going to have a flushing, and it's pretty significant for those of you that have not seen it. It's almost a little scary. It's like the patient looks almost red, basically red, and it's scary. They'll get a headache, a rebounding headache from it, because it's an acute vasodilatation causes a headache. Okay. Now, antihypertensive drugs may exaggerate the hypotensive effect of the nitroglycerin. And many of these patients that have angina already have atherosclerosis, already have hypertension. You know, when we get that list of drugs that the patient is on, and there's 3 or 4 of them, and they're not like, oh, geez, I like to take B12 because I'm under stress. we're looking at a different ASA classification, and these may be the ones you want to talk to your supervising dentist before you're left with them and say, now what would you consider baseline? What do you want me to do with blood pressure? How far out of normal? Is it okay for me to see this patient? Should we get a medical consult before this patient comes in? You know, in the ideal world, we always prepare for the day ahead, okay? And the last drug that has just been put into the emergency kit is aspirin. And aspirin is one of the more newly recognized life-saving drugs. The purpose is to, during myocardial infarction, is to prevent the infarction itself by catching it at the ischemia stage, where the platelets are just starting to gather, and give the antiplatelet so you don't get a complete thrombus. And that's the thought of it. So as soon as somebody has chest pain, we're to give the 162 milligram aspirin. There's a brief period of time where aspirin can have the benefit, okay? So we want to get it early. We put it on board early, and this is one of the drugs that probably I would feel comfortable with my hygienist going ahead because she's very adept at CPR, okay? And only contraindications are if somebody's allergic, or if they have a history of gastric bleeding, or if they have severe asthma. Okay, asthma's not a good drug for our asthmatics. Okay. Now, there has to be someone assigned in the office that's checking the inventory of all these drugs. When do they expire? An inspection should begin at regular intervals, and it was suggested by the Institute of Medical Preparedness that we use the same timetable that the firefighters have asked us to use with our battery detectors and our smoke detectors. So every time I hear the smoke detector thing from the firefighters, they usually have a big public parade of that. You know, that we're changing times, check your battery in your smoke detector. I always go in my office and say to my hygienist, did you check the meds? Do we need to order new meds? And that's just a good reminder. And so I like that, and that may work for you in your practice as well. Now, an oral carbohydrate source doesn't have to be in the kit. Okay, it can be in your refrigerator downstairs. It can be in your candy dish, providing it's not sugarless, at your front desk. But we need some kind of oral carbohydrate source. It can be a simple pack of sugar, it can be some orange juice, or it can be those cake makes, or you can buy this more expensive one that comes in the kits just for convenience. Now, that is used in the conscious patient, somebody that's still responding, they're weak and thready, they have a known sugar reaction, and they're usually better at telling us, I need to get a piece of candy or I need to get something, I'm feeling a little shaky, right? And when does this happen? This is probably one of the more common things that happens in our dental office, right? People are rushing, they don't want to be late, they come in, they've taken their insulin, and they just grabbed a quick bite on the way in. The appointment was supposed to be scheduled at 9. We had some problems with the patient prior to them. They sit for maybe another 25 minutes. They get into their chair, and you've got an hour appointment plan, and it's getting towards the end of the appointment, and they're starting to feel a little shaky, okay? And they're telling you, you know, I'm not feeling 100%. I got to get something. And they'll start searching through their bags what they have. You know, make sure we have orange juice, something right there to give them, keep them in the chair, keep them supine. And we'll talk a little bit about that in a little bit. Now, another drug that's not necessarily in the kit, but is available in most dental offices is nitrous oxide. And many of you are probably going to be certified now to give nitrous oxide, and so you're supposed to do that only under a supervision situation, but you'll have to speak with your supervising dentist and say, in an emergency, if the patient has severe angina and we can't control the pain, would it be okay? Would it be okay? And that'll be a decision everybody will make on their own algorithm, okay? But nitrous oxide works very, very well for an acute myocardial infarction and significant pain until the paramedics come on board. And most of these fail-safe machines come with 30% oxygen already being delivered, so it's a good titration, okay? Now, the last drug that is in on my particular kit is benzodiazepine. Personally, I don't ever particularly see myself giving this drug. Okay, it's there. It's for the management of a seizure that will not quit, status epilepticus. Okay, and it's not realistic in a dental practice to believe that somebody that's experiencing a grand mal seizure, tonic-clonic contractions, that you're going to start an IV line on them. I mean, realistically, you know, the hospitals have IV teams, emergency medicine, that's what they do. But realistically, we would struggle doing that, okay? We would struggle. So we have to have something that is water soluble. So the ones that we use are either midazolam or lorazepam, and they're used because they're a muscle relaxant. And remember, the number one problem with seizures that are not stopping is the patient can't breathe, right? They can't breathe. But on top of that, we can't ventilate them well. We can't get the muscles to recoil. So we're doing this in an acute emergency, but if you don't inject these carefully, we can get into more trouble than it's worth. And so in my particular practice, I'm going to get the EMTs on board as soon as the seizure begins. I'm not going to wait the 2 to 5 minutes to see if it's going to get worse. But I'm more conservative. Somebody else may say most seizures are self-limiting. I'm going to wait 2 to 5 minutes. But then if they wait another 30 minutes for the EMT, this could be a problem, okay? So in my practice, we do it differently. But it looks like this, and it comes in, you just clean the stopper, and you inject it. Now, if in fact you're going to use those, or use any sedatives with triazolams or benzodiazepines, you could have in your emergency kit the reversal agent if you're going to titrate people, and that's flumenazole. And it is dosage is 0.1 to 0.2 milligrams intravenously. And as I said, the possibility of us getting this IV on this seizing patient, probably remote. I think some of these things are placed there commercially, and really we're not going to ever use them. We have this equipment in addition to the drugs in the kit. And the equipment is a small amount of stuff that we need: the stethoscope, the blood pressure cuff, the oxygen delivery, syringes, needles, charting form. Find some kind of charting form that you can write down the times and what the blood pressure, etc. And a good rule of thumb, have a flashlight. You never know if this happens during one of those times where the electric goes out on us, okay? So have a flashlight right with that. Remember that we're still going to assess the airway in most medical dental emergencies. Don't jump on the chest. The only time we're going to do that is if the carotid pulse is not present. We're going to have the supplies to assist the non-breathing patient. We're going to have these all gathered in one area. The supplies we're going to need are the clear pocket masks. Some of them come right within these kits. This one happens to have a one-way valve, which good ones do now, right, which keeps what? The patient's expired air from entering us, okay? A better situation is to use the bag valve, okay, the bag valve mask. This is what all healthcare professionals should be trained and ready to use. What it does is it's an adjunct to provide positive pressure ventilation to the patient. It can be used with an oropharyngeal or a nasopharyngeal airway to keep the tongue away, and it can be used with the intubated patient. It's used, the fingers are put like an E around the lower bony border of the mandible. The thumb is placed on the top of the mask, which covers also the nose, and we press the bag and deliver the oxygen to the patient. Now, they can also have a little oxygen port that hooks right in and increase the amount of oxygen over room air, okay? And some of those also have a bag that's attached to them, like a reservoir bag. That bag, again, does not need to be inflated to have that oxygen or that bag valve mask working, okay? It doesn't need to be blown up like a balloon to be working. So don't be alarmed if there's nothing in it, okay? The AED, the dentist should consider having external automated defibrillator? Most offices, I would say, do not have these yet. Okay? So if, in fact, your office does, it has to be part of your scenario of what is it your doctor would like you to do. Okay, what would he like you to do? If I come in and you're seeing me and you have one of these and I'm having a coronary and I have no pulse, I would appreciate it if you go ahead and take my permission right now and use it on me. Because the greatest survival rates happen when we get early defibrillation within 8 minutes. And I don't believe that the emergency vehicles are going to be within 8 minutes. So you go ahead and take my permission to use it. Now we're going to have injection supplies, and they include needles of some gauge and length, right? And syringes of some gauge and some volume capacity. Now, you couldn't get 3 dentists in a room to agree what size needle to do an inferior alveolar block with. So whatever they have in their kit, that's fine, okay? I'm just giving examples of needles and syringe kits, etc. But the smaller the vial, the smaller the barrel you're going to need, okay? So if you have 1 ml of epinephrine, you're going to pick up, if the doctor says, load that up for me, you're going to pick up the smallest syringe barrel you can find. If you have 5 cc's of something, you're going to pick up a larger barrel, okay? And there's, and then you'll express it out. Everyone should know how to load a syringe. Everyone should know how to express air from a syringe, right? We get most of our newer hygienists graduate now being able to give injections, so they're very familiar with the technique. But every one of us in an emergency should have those basic skills, all right? Because it won't look good if we're fumbling around with packaging, okay? It won't look good, nor was it good for the patient. And so then we're going to inject the patient, and possible injection sites are the deltoid, the vastus lateralis, and that's where that usually goes in for an EpiPen, right into the side of the leg. It tells you inject it right there. The ventral gluteal, hip, and gluteal, we don't normally undress our patients and do things in the hip. They're usually sitting on their buttocks, and so we don't usually use that one. But everybody always says the intralingual. But remember, in an emergency, sometimes the mouth is tough to get open, stay open, move the tongue, it's flaccid, so I'm not so sure it's as easy as what people say it is. Probably the deltoid is indeed our most accessible, or this lateral thigh, okay? And so how are we going to give it? Everyone should know what needs to be done, because you're going to be prepping the site sometimes for the physician or the dentist or whatever that you're helping. And so you're going to cleanse the site with an alcohol pad, grab the muscle, hold the needle like a dart, quickly insert it, aspirate, and inject. Okay, and then you're going to remove it, put the dry gauze, and rub the area and put a little Band-Aid on. Okay, so it looks like that. You load it up, take about 3 fingers down from the shoulder, brow to thigh, start it, put it in, aspirate. If you're going to do it, like with the epinephrine or whatever, you're afraid you're losing the patient, they're still not here, and the EpiPen is sitting there, and the patient has a little, says, I'm allergic to this, and they've just had it, I don't know if you're going to do it. I say be deliberate. Okay. So far this morning we've covered how to prevent it. Know the patient. What drugs should be there for prevention in case we get into this problem, right? What systems may be our reactor systems that are creating